would like to welcome all the Sudanese pediatricians in our fourth session. Before to tell you who is speaking today to this fourth session, I would like to thank Dr. Abdelhadi Abdul Jabbar for this great idea, النشاط الأكاديمي اللي بدأ، والدكتور كريم الدين صالح يعتبروا مؤسسين لهذه النشاطات، ومع ساب KSA اللي هو اللجنة الأكاديمية لساب، وكذلك السودان مجلس التخصصات الطبية. ساب بيمثلوها دكتور طه ودكتور محمد زين كرار والدكتورة فتحية. these sessions recorded. ننوه الناس انها هي ريكوردد، وحتبث اللينك حقها في اليوتيوب، وهيكون بعد كل السيشنز بيكون في الجروبات موجوده باذن الله. second thing انه الكيو ان اي نحتاج انه الناس اذا عاوزه تسال ممكن you can share your question في الكيو ان اي وليست في الشات. و if anyone would like to talk directly he can raise his hand، برضه ندي الاوبشن ده في الاسئله. the one responsible for the question for today and answer دكتوره فتحيه محمد طيب الشيخ. وبرضه يا جماعه حيكون في ان شاء الله feedback form later ان شاء الله. والبرزنتيشن الباقي ان شاء الله حيكون في 3 sessions في 7 فبراير 14 الثالث لهذا السيشن، وبعدها حنتوقف في رمضان، وبعدها حنرجع بعد العيد بحول الله. المطلوب من الناس تكرما يعني يعرفوا نفسهم انهم موجودين وين في السودان وكده، او في السعوديه او في الامارات، في through chat. today we'll start with Dr. our speaker today, Dr. Abdelazim Muhammad Mabrouk. He's a consultant pediatrician and clinical associate professor في العين. دكتور عبد العظيم welcome and you can start.
السلام عليكم and شكرا يعني على الفرصة للمشاركة في هذا النشاط العلمي الكبير، ونتمنى إنه يستمر دائما. Today I'm going to talk about a very important topic in pediatrics, that is rare disease scenarios, a general pediatrician perspective. The objectives of this presentation is to define rare and orphan disease, and to define global developmental delay, and to present real case scenarios of children with rare disease, and to discuss conclusion and take-home messages. Rare disease is a condition that affects fewer than 1 in 2,000 people, and the prevalence is between 5 and 7.5 in 100,000. And while individual diseases are rare, the total number is large. There is a lot of rare disease now, every now and then added to the list. Orphan disease is rare disease that drug companies are not interested in adopting them to develop treatments. عشان كده بسموهم orphan disease. Child development, we have the basic 4 functional areas of child development, that is gross motor, vision and fine motor, hearing, speech and language, social, emotional and behavioral. Delayed children, what is developmental delay? A child does not reach developmental milestones at the expected time in a specific domain. For example, a 10-month old child fails to walk independently. This is gross motor delay. Global developmental delay in 2 or more domains of development. Example is a 24-month-old child says no single word and fails to walk independently. This child has delay in 2 domains, that is gross motor and speech delay. This is this child has global developmental delay. And global developmental delay, there is high probability of genetic syndrome, and it is an indication for genetic testing. Evaluation of the child with global developmental delay. The basic thing and the most important thing is detailed history and examination, audiology and ophthalmological assessment, metabolic studies, EEG if history of seizures, consider screening for autism or a language disorder. Now, autism is a real epidemic. The last census from America, like 1 in 32 child, very common. That is now the recommendation. Normal children visiting the clinic in 18 months, well baby clinic should be screened for autism. So if there is a close family member with global developmental delay, obtain a specific test for that disorder, cytogenetic screen, subtelomeric rearrangement. If there is no family history, are there features suggesting a specific diagnosis, genetic diagnosis, dysmorphic feature? You ask for a specific test. CNS injury or malformation, asphyxia, seizures, cerebral palsy, MRI, environmental problem like lead exposure, you do lead screen, loss of regression of milestones, developmental milestones, you do a comprehensive evaluation like MRI, metabolic testing, EEG, and cytogenetic screen. This is the MCAT. Now we are doing it for all children and 18 months. It is valid screening in toddlers between 16 and 30 months of age to assess risk for autism spectrum disorder. Like this child, he came for the 18 months well baby visit, and his score here is 12. And this is online questionnaire. The high risk is between 8 and 20. Immediately, this child should be referred for diagnostic evaluation, as this test is very sensitive in detecting autism. Genetic tests, the gold standard for global developmental delay is the genetic testing. And the next generation sequencing techniques dramatically improve the diagnosis rate for previous undiagnosed rare disease, like the whole exome sequencing and the whole genome sequencing. In this paper, they found that few pediatricians would order genetic testing, and few will refer for a geneticist specialist. Most will refer to developmental pediatrician, and many of them will not refer. The barriers for getting a genetic evaluation, service availability, pediatrician privilege. Not every pediatrician is entitled to ask for genetic testing. Parents' acceptance, many parents will refuse. And this is a very difficult situation to do this genetic testing. And the cost, this is a very expensive testing. And most of the insurance companies will not cover this testing. And genetic and developmental specialists are very few. Yani, very few clinics for pediatric genetic and for pediatric development clinics. Diagnosing children with rare disease is crucial first step in management and improving the child's future. It improves treatment outcomes. Early intervention can stop or slow the disease progression. As access to specialized care allows for specific tailored treatment plans and screening, preventing unnecessary and inappropriate medical procedures. Stopping the diagnostic odyssey. It provides families with answers and clarify and clarity after years of searching, reducing the immense emotional and financial burden. Reproductive planning and family screening determine risk for future children and enables screening for other family members. Access to support and clinical trials. Connect families with specialized resources, support groups, and clinical trials for new therapies. Education and social support helps parents access proper school resources and supports for their child. The rare disease odyssey is a common case scenario for misdiagnosis and diagnosis delay. Patients see about 7 doctors in average before correct diagnosis, and it can take up to 3 to 9 years to reach the correct diagnosis, and this adds to the suffering of the children and families. Why? To diagnose this disease because recent advances in precision medicine enabled providing treatment for rare disease. A lot of disease like Pompe, Fabry, Ehlers, Gaucher, spinal muscular dystrophy, tyrosinemia, Duchenne, beta thalassemia, sickle cell, and the list is increasing every day. And for this, children with global developmental delay unite a multidisciplinary team, which consists of a specialist health visitor, dietitian, social worker, psychologist, speech and language therapist, occupational therapist, physiotherapist. And the role of pediatrician is to assess the child, do the investigation, reach the diagnosis, continue medical management, coordination of input from therapists and other agencies like health, education, and social service. This multidisciplinary team is very important in the management of these children. Now I'm going to present rare case scenarios from the clinic. This is the first child, 5-year-old girl presented with abnormal gait. You see this sign? She has a positive Gower sign, increased lumbar lordosis, calf muscle hypertrophy. And this all point to a proximal myopathy. What is the differential diagnosis of this child? She is a girl.
We have Dr. Fathia. They are writing in the chat.
Yeah, I can see Duchenne muscle dystrophy, but he mentioned already this is a girl, يعني.
Yeah.
So we need another differentials, including these.
Duchenne, I can see Becker and I can see dermatomyositis.
Yes,
Some people
and
they are
SMA.
saying DMD lionization.
Yeah, maybe autosomal recessive muscular dystrophy.
Yes.
So
Some people
delayed
SMA
motor
type 3.
skills, no dysmorphic feature, bright and alert, positive Gower sign, waddling gait, hypertrophy of the calf muscle, exaggerated lumbar lordosis. These are gross chart, faltering gross. CBC normal, urea electrolytes normal, CBK normal, nerve conduction studies normal, EMG normal, MRI brain normal. So what other tests we can do?
We have Dr. Nafisa, she's saying Baker, SMA, dermatomyositis, kosher debris. They are saying in the testing, they are saying genetic testing.
Yeah.
Yeah, in addition to muscle biopsy, also mentioned by another member.
This child will not be diagnosed unless you do a genetic test. That is the value of doing a genetic test. So the whole exome sequence is pathogenic variant of ryanodine receptor 1 gene, the only gene associated with central core disease and malignant hyperthermia. This is very important diagnosis because if you want to take a muscle biopsy under anesthesia or any procedure under general anesthesia, these children are susceptible to malignant hyperthermia, which is a very serious clinical problem. The prevalence of this myopathy 6 per 100,000. This is the commonest congenital myopathy. This child was diagnosed at the age of 4, so this is a rare disease odyssey, which we talked about. These children, most of them will be diagnosed late. This is the first paper published about this disorder, firstly described by Shah McGee in 1956. It is an allelic condition due to autosomal dominant mutation in the skeletal muscle ryanodine receptor 1 gene in long arm of chromosome 19, encoding the skeletal muscle sarcoplasmic reticulum calcium release channel. And there is a high risk for malignant hyperthermia with anesthesia, as we said. This is a first muscle biopsy done for the first child in 1956. It showed areas devoid of oxidative enzyme activity, histopathology reporting in 1956. This is a core. That's why they call it core disease. Okay. The second case is a 5-year-old boy presented with large umbilical hernia and global developmental delay. There is, this is very big umbilical hernia. There is sagging cheek, redundant skin over neck, axilla, and knees. Excessive skin wrinkling and marked skin elasticity, faltering growth, chest X-ray normal, echo normal, abdominal ultrasound normal, X-ray hip dislocation. Any suggestion for the diagnosis? Actually, this case, I saw it with Professor Zain Karrar in Bahri and referred to us by the surgeon because he said he cannot do umbilical hernia repair for this child. Just, he said, this is one of your syndromes. Just check what is that and tell us. And when I showed it to Dr. Zain, he didn't tell me the diagnosis. He gave me a lot of reasons. Just go and read about it and tell me the diagnosis. And I found that most of the cases of this syndrome was reported by Professor Zain and Professor Idrisi and Professor Kamal Arabi in Saudi Arabia. A lot of publications they did on it. And I got the diagnosis from these papers. And I remember we presented in the clinical meeting. Any suggestion?
Yeah, they put mucopolysaccharidosis as differential. Any other differentials?
There is, I can see Ehlers-Danlos, Rumbelli. Dr. Yasser Bashir is writing BWS. Brother Willie, I think he's saying. Mucopolysaccharidosis. Larson syndrome, cutis laxia, Kabuki.
You see here? Who said cutis laxa?
We have 2 or 3 they
Dr.
are saying.
Rawiya Sulaiman.
This is
Rawiya,
cutis
Dr.
laxa
Nafisa.
syndrome.
Dr.
Yes.
Nafisa.
The prevalence in 1 in 2 million, and the case reported in the literature almost like 400, and age at diagnosis of this child at 5 years. It is a rare disorder of connective tissue caused by mutation in fibulin gene. In COP 1888 described loose skin disorder, and Debris 1938 describes the autosomal recessive cutis laxa, and this is the commonest type. Our child is in this Debris criteria. And after that, Professor Zain asked me to write a case report, and this is the first case report I wrote it, and it was a very excellent educational opportunity with Dr. Zain, and we published it in the Annals of Tropical Pediatrics, cutis laxa, growth retardation, and hip dislocation in Sudanese children. The third case is a 4-year-old girl presented with constellation of 3 features: severe anemia requiring blood transfusion, monogenic diabetes with negative antibodies, hearing loss requiring cochlear implant. When you have constellation of features like this, there is a high probability of genetic syndrome, and it is an indication for genetic testing. Anemia in a child with deafness, be vigilant for rare cause. This is the audiogram of the child, profound bilateral sensorineural deafness, more severe in the right ear, very severe. This is ECG, her ECG, ventricular bigeminy corresponding with brachydactyl premature ventricular contraction, mainly at the left posterior fascicle. These children are susceptible also to arrhythmias. Anemia, diabetes, hearing loss. Any suggestion?
First suggestion is Rogers syndrome.
What is that?
Rogers syndrome.
Roger. Okay.
All suggestions Rogers syndrome. DDMOD.
Didmont.
And Alport syndrome, Wolfman, mitochondria. Jervell Nelson.
This child has, yeah, he's right. Terma syndrome or Rogers syndrome. That is thiamine responsive megaloblastic anemia syndrome. And the prevalence is less than 1 in million. Pedigree reported almost 50. Age at diagnosis child 4 years. You see, again, this is the odyssey between 3 and 9 years, I said. And this is the first case reported by Rogers in 1969. It is an autosomal recessive disorder defined by triad of monogenic diabetes, megaloblastic anemia, and sensory neural deafness caused by transport defect of thiamine P1 into cells. Diagnosis clinical and confirmed by sequencing analysis of the solute carrier family 19-member 2 gene. Encodes for high affinity thiamine transporter in the bone marrow, pancreatic beta cells, cochlear cells. It responds in varying degree to thiamine. The problem is this child, the diabetes was followed by the endocrinologist, the anemia by the hematologist, and the deafness by the ENT. But when there is a triad like this, you have to think about a syndrome. The management is very easy. If you reach the diagnosis, thiamine is very cheap. Started on thiamine tablets, 200 milligram daily. Anemia, hemoglobin level increased from 5 to 12.9. Diabetes, hemoglobin A1C improved from 10 to 6 and 7.5, but it's still requiring insulin. Hearing loss, hearing aids with little benefit, so cochlear implanted. And there are some reports that if you do early diagnosis or prenatal diagnosis, you can interfere with the hearing loss, but still this child required cochlear implant. And the child gained growth significantly improved with initiation of thiamine. You know, here he started to gain weight. This is the lab. The blood film showed mixed hypochromic microcytic and normochromic normocytic with moderate macrocytosis because he has hemoglobin A2 of 4, that is high. He has beta thalassemia trait, so it is a mixed blood picture. And you see here the hemoglobin after thiamine responded significantly. This is a very rare case, important to present and publish discovered cases as they recommended. So we publish it with Professor Hadi Aburawi from UAE University. The 4 cases, 11-year-old boy presented with tics, eye blinking, tongue protrusion, shoulder shrug, OCD, hand, this obsessive compulsive disorder, hand washing, cleaning ritual, checking behavior. The most important thing is the deterioration in scholastic performance and memory, became very forgetful. And what worried the patient? The child used to كان حافظ أجزاء من القرآن. He started بدأ ينسى كثير من الصور، عشان كده الأهل كانوا very worried. He became very hyperactive and impulsive. His emotional liability, running from home. He developed secondary nocturnal enuresis. The only test positive was positive throat swab for beta hemolytic streptococci, and he has high ASO titer. Tics with this feature, what's the diagnosis? Any suggestion? And his scholastic performance.
Everyone is saying Banda.
Yeah. Neuropsychiatric symptoms preceded by upper respiratory infection. This is BANDAS, pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. First reported, or this is a pioneer in BANDAS, Suzanne Sfido from USA. We collected some cases and published it in Journal of Tropical Pediatrics, and all of them share the same feature, abnormal movements like tics preceded by upper respiratory infection, psychiatric symptom, OCD and tics, high ASO titer, positive throat culture for group A beta hemolytic streptococcal. And BANDAS is a neuropsychiatric disorder that brings mental illness to its biological roots. Estimated incidence 1 in 11,700 for children between 3 and 12 years. Although some reports reported that it is between 1 and 200, 1 in 200. Group A beta hemolytic streptococci trigger an autoimmune reaction in genetically susceptible children. This leads to the development of neuropsychiatric symptoms. And you have to suspect in any child with tics and OCD that exacerbated after upper respiratory infection or scarlet skin rash. And interestingly, some of these children respond to antibiotics. And this is not a good thing for our friends, the psychiatrists. When you give the antibiotic, most of the feature will disappear. This child, 3-year-old boy, presented with macrocephaly and global developmental delay, recurrent seizure, global developmental delay, delayed walking and speech, regression of milestones, frequent episodes of fever, irritability, vomiting, and crying in pain. Just remember this feature: fever, irritability, vomiting, and crying in pain. Appendectomy and volvulus reduction done. The child was dysmorphic with core feature, depressed nasal bridge, and low tears, large head, significant faltering growth, and his height in the 25th centile. This is large head with low set years, macrocephaly in the growth chart. Workup, ammonia normal, lactate normal, urine plasma amino acid normal, organic acid normal, urine mucopolysaccharides negative, karyotype 46XY male. This is the MRI. Showed extensive cerebral white matter change, frontal predominance, T2 increased signal and T1 decreased signal. Any suggestion?
The first suggestion is Canavan.
Canavan. Actually, the radiologist is a very good radiologist. He spotted this change, which point to the diagnosis.
Alexander. Again, Canavan. MS.
This is the report from the radiologist, highly concerning for Alexander disease, fibrinoid leukodystrophy. The whole exome sequences showed autosomal dominant Alexander disease, confirming the diagnosis. But the interesting thing, the incidental finding of autosomal dominant familial Mediterranean fever. And maybe this fever and crying and vomiting may be due to the familial Mediterranean fever, because the child was not, he's non-verbal, he's not speaking, non-complaining, but only crying from pain. The story continued. His 8-year-old sister presented with recurrent abdominal pain, joint pain, and febrile episode, and frequently admitted to the ER, and to the extent that appendectomy is going to be done. But after the diagnosis of this child, familial Mediterranean fever gene done, and it was positive. And she had a very high serum amyloid A. So familial Mediterranean fever also is a common case scenario for misdiagnosis and diagnosis delay. Frequently, diagnosis can be made due to a diagnosis in a relative, like in this case. This is the first case report of Alexander disease. The prevalence is less than 1 in million. The case reported 500, and the age of diagnosis of this child 3 years. It is a progressive fibrinoid leukodystrophy, autosomal dominant mutation in chromosome 17 in glial fibrillary acidic protein gene. Diffuse myelination in the frontal lobe, usually a fatal neurologic disorder. Unfortunately, this child passed away, and his sister familial Mediterranean fever was controlled in colchicine, and her amyloid dropped dramatically. This is a 3-year-old boy presented with generalized hypotonia and global developmental delay. Mother noticed child not rolling over and not holding head up. Dysmorphic feature, broad nasal bridge, upward slanting palpebral fissures, ENT hearing loss, ophthalmology iris coloboma. The striking feature of this child is marked head lag. Also, all the investigation, including CK, EMG, nerve conduction, MRI, all normal. What is the differential diagnosis? Again, this child will not be diagnosed unless you do a genetic test, because it is a very interesting diagnosis.
They put here SMA, Zellweger syndrome, Charge syndrome, botulism, Down syndrome.
The whole exam sequence of this child showed the diagnosis of Temtami syndrome. Gene C12, open reading frame gene 57. The zygosity, it is homozygous, inherited from mother and father. The mode of inheritance is autosomal recessive, and it is a pathogenic variant. The prevalence less than 1 in million. Case reported 46. Age at diagnosis of this child is 3 years. This is the first case report of Timtami syndrome described in 1996 by Samia Timtami, an Egyptian geneticist. And this Samia Timtami described a lot of genetic syndrome which we know in pediatric practice. She was working in Saudi Arabia for a long time, I think, and in America also. Timtami syndrome is a autosomal recessive multiple congenital anomaly syndrome caused by mutation in chromosome 12 open reading frame gene. And in this paper by Rakaf et al., they concluded that this genetic mutation is among the most common recessive causes of intellectual disability in Arabs who trace their ancestry to Saudi Arabia, should be considered in the etiology of developmental delay intellectual disability, even when typical syndromic features are lacking. So for most of this global developmental delay in the Gulf and in Saudi Arabia, Timtami syndrome should be considered because it's many cases reported in families over there. This is a 9-month-old boy presented with marked hypotonia and global developmental delay, bright and alert, no dysmorphic features, marked head lag, no rolling over, no crawling, no sitting without support, no standing when holding, no saying mama and baba. And the striking feature in this child is frog-like position. The investigation including CBK and brain MRI, all normal. What is the diagnosis? Any suggestion?
Not yet. Not
We
yet.
can see SMA. We can see SMA in the comment. Until now, SMA is the
Yeah.
أيوة.
The genetic test showed that
Verding-Hoffman disease also, yes.
Yeah.
SMA Verding-Hoffman disease.
Yeah. The genetics test reveals that this is MN1 gene, homozygous pathogenic deletion in exon 7 and 8. SMN2 gene, 2 copies of exon 7 and 8 are identified. Diagnosis, autosomal recessive spinal muscular atrophy type 1. And Verding-Hoffman disease is the neurogenic dystrophy described by Werding in 1891 in this paper, and the spinal nature by Hoffman in 1893 in this paper. And the prevalence is 1 in 100,000, 25,000 American, and 1 in 50 carrier rate. So it is common. Age at diagnosis, 9 months, and it is a bit late for this child to be diagnosed at 9 months. It is a degenerative neuromuscular disorder manifest as truncal weakness before age 1 in severe case, caused by SM1 gene mutation in chromosome 5, historically fatal in early childhood. And we saw a lot of some cases before, and most of them pass away before they are 1 year old. New treatments are effective but expensive, and this boy was among the first SMA children who received the Lingdegma gene therapy in use. They sent him to America. One-time intravenous infusion, it costs about $2 million. Now it is available in most of the Gulf countries, including UAE. So in conclusion, while individual diseases are rare, the total number of rare diseases is large. Children with 2 or more developmental delays, that is global developmental delay, have higher risk of genetic disorders. General pediatricians are responsible for referring them to get genetic evaluation as first step in workup, because most of these cases cannot reach diagnosis without a genetic test. These are the references. Thank you very much.
Thank you so much, Dr. Abdelazim for this nice talk. Professor Sati Abdelrahim.
طيب السلام عليكم ورحمة الله. صوتي مسموع؟ ألو؟
أي نعم واضح.
واضح.
طيب شكرا دكتور عبد العظيم محمد مبروك. Really you travel us in زي ما بقولوا رحلة دسمة لسيناريوهات يعني really with a very excellent presentation and explanation and discussion and how to present it وكده، وإنه how to reach a diagnosis by this way of finding the symptoms and signs, and then you try to look which diagnosis is fitting on these children وكده. وكانت يعني صراحة دسمة في a lot of diagnosis تكون عصف ذهني لهم، على أساس إنه يعني ما ياخذوا الكيسز just straight forward like that some diagnosis common ويفكروا في الأشياء زي دي وكده يعني. ف really very good. أنا بس كان عندي زي query أو question about Alexander syndrome and القضية بتاعت الفاميليال ميديترينيان فيبر. اتذكر قبل يمكن 15 سنة ولا حاجة in our country في السودان، أنا ودكتور محمد جمعة و some physician we find some cases of familial Mediterranean fever، وحتى كنا عملنا لها presentation في واحدة من المؤتمرات على أساس الناس يفكروا في a disease like that which is forgotten usually، والناس ما بيفكروا فيها وكده يعني. فداري نعرف يعني more information about this Alexander and familial Mediterranean fever و how you connect this and more explanation. وشكرا جزيلا دكتور عبد العظيم.
شكرا Professor Sati. I don't think there is a clinical correlation between them, but as you see in the report, it is an incidental finding. يعني هو يعني كثير مرات بيعملوا genetic test بيلقوا two different alleles. فthis is يعني just an incidental finding, but it explains the symptoms of fever and abdominal pain and crying and vomiting to the extent that they did appendicectomy for the child. And the useful thing for this diagnosis is that the girl who has long history of abdominal pain, fever, joint pain, admission, sometimes scheduled for surgery for appendicectomy. She was diagnosed after her brother was diagnosed, and she responded very well to the colchicine treatment. And everything, even the markers like amyloid A, dropped very significantly. But I don't think there is a clinical or genetic correlation between the two. Maybe it needs some research or studies to see if there are a lot of cases.
Yeah, I think also sometimes for high consanguinity, we can have more than like one autosomal recessive condition in one patient.
Yeah, the most important thing with this familial Mediterranean fever, most of them they diagnose late. In Turkey, where it is very common, they said the average, some cases are diagnosed as adults, some children at 9 years. And most of them will undergo surgery. And the most important surgery is appendicectomy. And they mix it sometimes with autoimmune disease like rheumatoid arthritis and these things. So we should put it in mind.
Dr. Abdelazim, thank you very much for your nice presentation. I'm Dr. Taha. just want يعني comment on what you started with global developmental delay and the diagnosis, the approach to these cases. I just want to add two things. This was especially for trainees for development. When you are discussing development, if you find a child with hearing loss, with concerns regarding speech, a child with concerns regarding speech delay, you need to think first of all about hearing test. This is very important. Think about hearing test. Well, same if you find a child with problems with fine motor, you need to think about checking the vision of the child first. This is very important للترينيز يعني. This is the first point. It's important to think about this all the time when you are seeing a child with hearing loss or fine motor problems. The other thing, what you said as well, this is very important. Take the parents' comments seriously. And I remember when I was in Ireland, I had a child with constellation of symptoms. A child has autism, cardiac problems, strange like dysmorphism, and I didn't know what it was seen. طبعا هناك we don't do يعني extensive genetics as part of waiting for genetics is very long. So what I did, a mother was saying, everyone is thinking that I'm crazy. I think there's something serious. وعند هذا child also he's autistic. فأنا قلت يعني I've done everything وكده لكن يعني also don't you know your limitations. فأنا I told the mother there's a possibility I can get a second opinion for you. فقالت لي yes, I think there's something, we are missing something. ففي النهاية طبعا I asked one of the colleagues to see the child. He came back to me and said, you've done everything. The only thing that I would do اللي هو كانت whole exome sequencing. فده طبعا هناك يعني it's cost around 2,000 euros. You need permission from the hospital, manager وكده. ففي النهاية it was diagnosed as cardiofacciocutaneous syndrome CFC, which is rare disease. لكن the mother was very happy that she got the diagnosis, although it's not going to change a lot, but it will, she has explanation for the symptoms and she has anticipation what she would do. مرة ثانية, thank you very much, Dr. Abdelazim. I appreciate your valuable presentation.
Thank you.
Thank you, Dr. Taha. So for questions, I have only one question here. There was a question about the difference between Wolfram syndrome and Rogers syndrome. I think the symptoms and the constellation of the symptoms, different presentations, like including DI, isn't it, Dr. Abdelazim?
Wolfram this is a dead motor. Diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. The mutation is different. I think it is a different genetic mutation. And you will find different things like, yes, there is diabetes, there is vision, DI, diabetes insipidus, diabetes mellitus, والثانية أظن إيش optic atrophy and deafness. And the symptoms are different and the genetic mutation is different. This is the main difference between them.
Sure, waiting for other questions. أنا حقيقي لفت انتباهي دكتور عبد العظيم. طبعا very nice presentation. لكن اللي لفت انتباهي أكتر إنه as a Sudanese pediatrician we started to report cases very early ما شاء الله in very well recognized journals يعني.
Dr. Fathiya, if you allow me, if there is no question from the other audience, I have question to Dr. Abdelazim.
Sure, Dr. Abdelazim, تفضل.
Dr. Abdelazim, and I see before my question in the webinar chat, there is many thanks for you and da'wat bil Jannah with this nice presentation. طيب, let me go to the question. For the case with Gawar sign, and this question, I think also for the trainee, يعني. She is female, and the case, when I see Gawar sign, my first diagnosis, I will think of Duchenne muscular dystrophy, and she is female. يعني any need to look in this female for the signs of Turner syndrome, like weak neck, posterior hairline, and other signs, and going to send for karyotyping before send whole exome sequence. And also, I think Dr. Prof. Saleh, he diagnosed another case with another gene in female with Duchenne muscular dystrophy. Dr. Abdelazim.
I think the karyotype you can do initially for anyone because it is cheapest and it is available in many places. But I think Turner, there is specific features. We saw some Turners here, and they are classical features. But the problem is that also late diagnosis. Most of them, the one we saw here, diagnosed after the age of 10 years. That is why Turner should be suspected earlier with the dysmorphic feature and these things. And with Turner, I think it is a bit different from this syndrome because this is mainly a muscular dystrophy, and Turner, a lot of dysmorphic feature, a lot of constellation of features which can point to Turner. But yeah, it is good to do a karyotype in any child with developmental delay because whole exome or whole genome, it is not always available, and it is very expensive, and not everyone can do it.
Dr. Mohammed Zain, if you can allow Professor Isa to speak.
Prof. Isa, you can speak. You can unmute yourself, please.
السلام عليكم ورحمة الله. كلام جميل جدا دكتور عبد العظيم وشرح وافي في مواضيع مهمة جدا جدا. طبعا كل الأمراض دي بتحصل لكل الناس يعني في السودان وفي غير السودان. عشان كده يعني نحن يعني إميون من هذه المشاكل اللي ما بنقدر نعمل لها يعني definitive diagnosis. لكن these diseases exist. these children يعني belong to families which are worried. فأنا مبسوط من الآخر جملة قالها الدكتور عبد العظيم إنه the general pediatrician should يعني try to get help from the يعني specialties concerned. هنا طبعا أكتر شيء neurodevelopmental يعني specialist و neurologist. لكن في other برضو problems يعني concern cardiologist or other problems. I think as a general pediatrician, if you are confronted with a problem which you cannot diagnose inside Sudan or within your facilities, you face the family. You either tell them, I don't know, or you tell them that there is no means of doing further investigations here. And this will gradually be absorbed by the family, and they can come up with solutions. Many times I faced this, and I thought there were no solutions, and parents had their own solutions, and they were working solutions, either to go to another country or to get help from other people. I think if you are honest with the family and you explain to them in details what you have done and what you have reached and where your limit is, this is a great job. And thank you very much.
Thank you, Professor Isa. I think Professor Sati, you are raising your hand.
طيب السلام عليكم. ارجع لك تاني يا دكتور عبد العظيم بالنسبه للكيس بتاعت الكسندر and his sister who is you were diagnose him or you diagnose him with familial Mediterranean fever. If you have more information about his sister, how she was diagnosed, what typical clinical symptoms, and when she started treatment, if she responded to that treatment, and how she is progressing about that, and if there is other cases related to her or not. وأكون شاكر جدا يعني. شكرا.
The problem is her sister used to present with frequent symptoms, fever, unexplained abdominal pain, joint pain, and this usually occur for 3-4 days and improve. Sometimes I gave her antibiotics, some her analgesics, sometimes admitted to ER just suspecting acute appendicitis. The good thing when she was diagnosed, her amyloid A was very high. It was more than 250 or so. The last amyloid was 6. That is the cutoff point of, and this is what you and CRB and everything, all the acute phase reactant, which is high during the episode, came to normal. But the most important thing is this amyloid A. It became like 6, which is the cutoff point for normal. And all the symptoms was controlled, and she is not presenting the symptoms like before. So it is good to diagnose her, because the tragic thing that most of these children or cases of familial Mediterranean fever will be suspected to surgery. Most of them, almost يمكن all of them or most of them will have like appendicectomy. This is the commonest. In one study, they found appendicectomy is the commonest thing they do it for them. And the commonest other diagnosis, in some areas, they diagnose them like rheumatoid arthritis, and it started on treatment for rheumatoid. So it is very important to diagnose them.
Thank you, Dr. Abdelazim. Last question, there is Dr. Abdelbagi. He mentioned that for the case of positive Gowar sign, the girl with positive Gowar sign, what was the MRI brain findings? Because he mentioned that they have the similar case, but MRI showed brain atrophy.
No, the brain MRI was normal, as I mentioned in the presentation. Everything normal, EMG, nerve conduction, MRI, all normal. And the child was very bright. She has no intellectual problem, only muscular dystrophy.
Okay, clear. Thank you so much, Dr. Abdelazim. Dr. Abdelaziz.
Thank you so much دكتور عبد العظيم for nice presentation. وسعيدين جدا اليوم كمان إن سمعنا صوت أستاذنا بروفيسور عيسى. و thank you for all audience. ونحن نسينا في البداية نبدأ بالقرآن الكريم، ولكن لما ما نبدأ بنختم بالقرآن الكريم. ومعانا ابننا الصافي يختم لنا بالقرآن الكريم، وجزاكم الله خير. وقبل ما يختم الصافي بالقرآن الكريم